Well, it's really a pleasure of mine to host again Dr. Vincent Rajkumar, great friend of the show and personal friend as well. He's been always generous with me, volunteering his time, as well as with the show, trying to educate the public about the various issues from COVID-19 to multiple myeloma. But today, actually, Vincent's going to wear a different hat. We're going to talk about something else. We'll talk a little bit about the pandemic, a little bit about scientific articles, but I want him to wear his editor-in-chief hat. He's going to tell us a little bit about that role. What does that entail? And we're going to talk about how things have evolved in terms of reviewing data and reviewing clinical information and trial information, from press releases to preprints to peer-reviewed articles to abstracts, all of these things, and how this really affects taking care of patients and the public acceptance to all of these platforms that have suddenly emerged. I'm very curious to hear, Vincent, your thoughts. Do you mind introducing yourself again? I think most of my listeners know who you are, but maybe shed a little bit more light on the editor-in-chief, the journal, and how, what is that role exactly? What do you do in that role?
Well, Chadi, thanks so much for having me. It's always a pleasure to talk to you.
Thank you.
And I know what you're saying. Most of the time when we talk, we're talking myeloma or costs, and today it's a totally different subject. I look forward to the conversation. As you know, I'm an active researcher, and I do laboratory research, clinical and AP research. But on the other hand, I also have been an editor for journals for a long time, many years now. I was an associate editor, section editor for leukemia for, I don't know, more than 15 years now, I have been, and also the Mayo Clinic proceedings for more than 10, 12 years as an associate editor, and as the editor-in-chief of Blood Cancer Journal, along with ILU, for at least since the start of the journal. So this has been an important separate portion of my career. And the job involves, like when you're an associate editor or a section editor, the job is really in processing the papers that are assigned to you by the editor-in-chief and deciding, whether to send it for peer review or not. And then if you do send it for peer review, looking at the peer reviewer comments and making a decision on how much revisions are needed or whether the paper is not suitable for the journal. And then the editor-in-chief actually takes the final decision. As editor-in-chief, the role is similar, but like the buck stops here. Ultimately, you have to decide whether to okay the article for publication or not. And it's a little bit more challenging because I don't have room for error. I don't have anyone else overlooking my shoulder to see if this is the right decision or not. So I am very careful in everything that I do when it comes to the Blood Cancer Journal in terms of, reviewing papers, assigning reviewers, and then deciding on the merits.
It's hard for me not to ask you this question because it's interesting, right? I mean, you eventually have to make a decision, and there are papers are slam dunk, right? Like, they have to come in, and papers where they're garbage, they're not going to come in. Garbage for your journal. But then there are these papers where, a reviewer likes it, the other one doesn't, and you know what I'm talking about. Have you ever accepted a paper and then you felt like, and the paper came on social media and it was like completely like the uptake was terrible, like it was contrary to what you expected, and at the same token, have you ever rejected a paper and then you saw that paper that you written in a different journal and really a lot of people were uptaking and you said like, I could have accepted that paper?
Oh yes, definitely that's happened both ways. Every editor is different, and people should realize that there are journals which have editors-in-chief whose whole job is being an editor-in-chief. They don't have a separate research career or anything that they are on their own doing research and publishing. They're in-house editors and they perform that as their main occupation. And then there are editors like me who have a totally full academic career and many times are in the field. And there are pros and cons to both. Like if you're already in the field, then you're biased by what your own beliefs are in the field. So if you get a paper that is opposed to your view as a researcher, and now you're wearing an editor's hat, you have a different role. And on the other hand, the pluses are you do know the field really well to know when the reviewers may not be accurate. And so there are some editors who defer to the peer reviewers. Like if two reviewers say this is a bad article, they usually reject it. Most of the time I would heed to the reviewers' thoughts, but there are many occasions where I disagree with all the reviewers, 2 or 3 reviewers, because I feel like the paper is actually quite good and salvageable, and maybe the reviewers' comments are not accurate. Because I am in the field, I am doing the research. So
how much time does this take of your like, is it 20%? Like how much is it a monthly, bi-weekly? I mean, I presume you get the papers every day, you get papers submitted. So how much work does that entail?
It is a lot of work because I'm doing 3 journals full, the Mayo Clinic Proceedings and Leukemia, and then Blood Cancer Journal. 2 of them as associate editors and 1 as the editor-in-chief. So between the 3, it's a lot of time commitment. And therefore I have taken, I'm only 0.8 at Mayo. So I have taken time off to make sure I have at least 2 or 3 days of the week. You have the weekend and then you have an extra day fully to devote to editorial duties.
Well, then you are the perfect guest to what I'm trying to accomplish here. And my goal is really to educate the public and educate myself, frankly, as well. So Vincent, you've been very active with the COVID-19, whether it is in the US, in India, and you kept your fingers on the pulse into what's going on. And I've always admired your opinions. We've had some disagreements, me and you here and there, but we've always had a lot of respect for each other's opinions. But what I want to highlight is what this pandemic has shown me is that some of the clinical information usually get disseminated and shared before a paper is ever published, and even before an abstract. Like we have been able to see information coming through press releases. We, on a website, we have been able to see information coming on a preprint server. Then we have information as an abstract for a scientific meeting and papers. I wanted to put your editor-in-chief hat. How do you evaluate this data? If you see press release, do you say I'm not going to look at it, abstract, it's missing? Like how do you assess this? Because your assessment could have clinical impact on patient care.
Yes, and I think you've clearly aligned the various formats in which information is coming to us. Press release, then the abstract presentation, and then the full preprint, and then the full peer-reviewed publication. And most of the time the discourse is that unless it's in peer-reviewed publication, it's not fully vetted, and therefore there might be problems with it. And so people just need to understand what is the peer review process and what it actually accomplishes. So if an article comes to me, I'm assigning it to 2 or 3 people who I feel are suitable experts in the field to look it over. Ask the authors for additional comments or revisions, or say that the data is not actually sound and reject it. What peer review accomplishes is if the authors are making a misinterpretation, or they're not analyzing it correctly, or they've analyzed it in one way, but there has to be additional analysis done in this other way. So those are all things that the peer, and also interpretation, whether they are interpreting the data correctly or not. All of that peer review accomplishes. What peer review does not accomplish is detect fraud. I mean, if somebody makes stuff up, peer review won't catch it. Peer review goes by the fact that the author is credible, the institutions that present the data are credible, and therefore, that's the whole assumption. Fraud is captured by other means, but it's not by peer review, unless there's like manipulation of figures or something like that, or plagiarism or something like that. But most of the time, fraud cannot be caught on peer review. So people should know that. So then when you have a press release come out in the time of
so before that, how long does it take the peer review? Like it varies, but how long, to give a sense to listeners the time?
Yeah. So again, you and I, when I started working in the field, all of the peer review was by regular mail.
Oh yeah.
Submit the article in regular mail, then it goes in regular mail to the peer reviewers. They may or may not want to review, and then so it takes probably sometimes several months for the article to get accepted, or a year or longer. And therefore, it actually made sense to have abstracts and press releases, because otherwise you'll never know the data for a year or more if it's an important piece of information. Nowadays, we try to make a decision within 2 to 3 weeks of submission, the first decision. From the time of the acceptance, we try to put it online within 2 or 3 weeks of that. So a good paper where the author is prompt with the revisions and requests for all of the information can be submitted like today, June 3rd, and then August 3rd, it could be out in print. Okay, the whole process is truncated now to that short thing. And if it's an important article, you can have expedited review. Some of the more high impact journals can have reviewers that would be willing to review in 72 hours and post it within 2-3 weeks of submission. So things have gotten better depending on what is the paper trying to say. If this is a new treatment that people could actually have, or if this is a change in the therapy that could be made based on this result, some journals will try to get this information out as quickly as possible. So the peer review process, even though it's an important component, it may not delay things too much.
So then that's for the actual paper. Now you said the preprint.
Yes.
Tell listeners what is a preprint, because I mean, 5 years ago, I don't know. I mean, preprint seems to be a new hot thing that have evolved over the past year or so. Is this a new thing? Has it been going on for a while? And where do people put it? Is there an actual website? Every preprint goes on? Like what's the process? Any insight into that?
Yes. And so just like we talked about peer reviewed papers and peer-reviewed papers and the process, what COVID has really helped us realize is the immense value of preprints, where someone could just post whatever they've written, the original research article or a review, and post it on one of these preprint servers. And there are many preprint servers available online which are well established, and they take submissions. Elsevier runs one big one. So those articles are not peer reviewed. They just submitted in a particular format, and it's not judged for whether it's high impact, low impact, whether the analysis is done the right way, but it has the raw data and it puts it out there. Now you have to ask, when you say what is the pros and cons of a preprint, the way at least I look at it is, let's say if there is a preprint on dexamethasone for treatment of COVID. Okay? If that preprint is out there, dexamethasone is a commercially available drug. I could change practice tomorrow if the drug is what they say it is. Then I go through the preprint and I put on the peer reviewer hat. After all, most of the people on Twitter who are not most, most of the people on Twitter are consuming the information, but there are all your peer reviewers, and most of your peer reviewers would also be on social media. And people who critically evaluate and comment on Twitter, let's say, at least with dexamethasone, the comments that I saw were from people who are peer reviewers. If this article had gone to a journal, one of us would have received this article for peer review. It's not like a whole different group of people called peer reviewers who are somewhat special. They're the same people on Twitter, and they read the same paper and they make their own assessment on what changes are needed or not. So when you have feedback from those kind of individuals on Twitter, then it's almost like they have peer reviewed the paper for you. The only thing that is missing is that it's not in the name of a journal, but it tells you all the warts. It tells you, yes, it's a good paper, but these are the problems. These are the additional analysis you need to do, and so on. So I looked at that paper with that kind of an eye, you know, wearing the editor's hat, wearing the peer reviewer's hat, and asking myself, have they gotten all the information listed that I need to make a call? Is there any analysis that's missing that's important to have? And if not, I feel like that paper is just as good as a peer-reviewed paper.
What's the benefit of why would the author put something on a preprint? Like, you know,
because they want the word out quickly.
I see.
If it's an important enough piece of information, they want the word out quickly, and then you can decide whether you want to use it to change practice or not. Now, preprints, I am not reading all the preprints. I'm reading selected preprints that are so critically important to me that will make a difference to my practice. Then I wear the editor's hat or the reviewer's hat and read the preprint critically and make my own impression, and so do other people. And
but,
so
but you know, Vincent, some might argue that not all people who read the preprint, you know, are, I would say, good analysts of clinical trial and good, you know, not everybody is going to be editor-in-chief of a journal and has the acumen of critically appraising a particular study. Correct. They may see the preprint and they read the abstract and read the conclusion, and they go ahead and do something with the data without really looking at the tables and the analysis like you do. So I could see the pushback into that. If the preprint is out there and people who are not as well qualified to critically appraise the study, they may start changing practices inappropriately. What do you say to that?
I think that's a very legitimate concern. That is an important concern of preprints, is that there might be people who read the article and make the wrong conclusion because they didn't look for all the analysis that should have been done. Keeping in mind that many peer-reviewed papers are also flawed, even if it comes out in a very top journal. And there are very big mistakes that are made in interpretation, conflicts of interest. So you want, and that's why whether it's a peer-reviewed paper or a preprint, unless you're confident of critical appraisal on your own, you want to see what other people who are confident of critical appraisal and who are good at critical appraisal say about it. So I don't think people should look at a preprint and jump to conclusions. But if they see 5 or 6 people who are qualified peer reviewers on Twitter saying that, yeah, we have looked at it and this looks good, then that's as good as you're going to get, because at least now the peer reviewers who are saying this is good are not anonymous. You know who they are and their credibility. So you don't need to just trust the author's name. Twitter is telling you that, hey, there are these 6 people who are qualified. They've all run randomized controlled trials. They are either experts in COVID or steroids or something. And they're telling you the UK trial is very legitimate. Waiting for 2 months or 3 months will only harm people. This is just important to go ahead. Then you should just view that as a non-anonymous peer review, you're getting live out in the
So,
open.
yeah, so I think I like this. So the preprint seems to be pretty convincing because you have these actual reviewers. So even if you are not an experienced oncologist, you see these experts who pontificated on that. And really, it's a matter of administrative issue between preprint and the actual
Exactly.
paper. But press releases are different, right? I mean, so tell us about press releases.
Exactly. So again, I saw with, I think the dexamethasone story is a good one because
Yeah, let's
we
use
have
it.
a specific example so we can look at it. So when all through COVID, I saw this, not just with dexamethasone, I saw this with remdesivir, I saw this with many things from the vaccines to everything, that there would be a whole group of people who says, oh no, we cannot do anything based on a press release. Why is the press release coming out before the paper? Or why is the thing? And I think the first thing to keep in mind is, unless people are living under a cave, that's how it's always been. The large randomized trials, the press release always precedes everything else. It may be timed to be coming out exactly on the same day as the abstract, but if it's a very important result that could affect the value of a company, then they don't wait for the abstract, because the abstract's not confidential. There are 5 or 6 reviewers who look at it. There are people whose eyes lay on it. And so if it's a trial that can affect the stock valuation of a company or something, they're bound to issue a press release to say, we did a double-blind randomized trial. We found this vaccine to work. And that's the press release. They have to issue it. And that happens with every oncology drug. I mean, all big oncology trials, you will see that there would, if the trial is positive or negative, there would be a press release that precedes the ASCO abstract, that precedes the ASH abstract. If it's a material conclusion, if it's an also ran trial which doesn't really, it's commercially available drugs, doesn't really affect outcome, you can wait for the press release to come out on the same day as the abstract presentation. But that's how it's always been done. So that's the first point. It's not new. That's how it is. Number 2 is, what is the content in the press release?
Right.
Most press releases, a good example will be Covaxin, that came out from India, is one of the vaccines that is approved and used in India. That has very scant detail. And it's impossible to use that to be sure what the real numbers are for the full trial. Okay? You have press releases which have even less information, which simply say that we did the trial, we found a significant benefit, here is the p-value, but you don't have the actual raw numbers, how many people had response or not, or died or not. And then you have press releases like the dexamethasone press release, where it pretty much has all the information that would have been in an ASCO abstract. It has the number of people, the total randomization, the link to the protocol, where you can look at the endpoints. And the endpoint is survival, which is not fudgeable. Either they lived or didn't live. And they tell you X% versus X%, and they give you a p-value hazard ratio. So you have all the information necessary to make the big call that you want to make. And it's almost, so I think it's easy to say, oh, it's a press release. That's very lazy, without looking at, oh, was it really just a press release? Or did it have enough information that would have otherwise actually qualified as an abstract?
So really, not all press releases are created equal.
Correct. It really depends on what's the content, and is the content good enough for me to make a call? A call almost like a peer reviewer. That is it intent to treat? Do I have the protocol so I can verify what the design was? Do I know how many events occurred? Do I know, is it an event that requires the data safety monitoring board to tell me that it's true or not, like it's, response versus no response, progression versus no progression? Or is it a slam dunk endpoint, like did the patient alive or not? And then what was the magnitude of the difference? what was the p-value, at that point, short of fraud, which peer review does not detect, there's not much that will change. Fraud or error in the calculation.
That's really, I think that's really a good point for listeners out there. Peer review cannot detect a fraud. If somebody falsifies data and put the table and makes up information, you can't really. And there has been some papers that fraud was detected later on.
Exactly.
And were retracted. That's a good point. So that's really interesting. So press releases are not always created equal. Anything comes to mind? You mentioned the COVAX as an example of a press release that did not change your management or recommendations, at least to the public. And then the recovery
actually was a press release that did change the management. We are just not happy about it. We would rather have the full paper.
I see. So how, like,
because it didn't have enough information in it. But because of the urgency of the situation, the vaccination is going on.
Right.
But the dexamethasone press release is one where it's got all the information. So years ago, for example, in 2005, I'll give you an example. I think real examples are good. I think 2005 or 6, we had done the high dose dexamethasone versus low dose dexamethasone.
I remember with lenalidomide.
In that study, we randomized 445 patients. At the end of 1 year, 96% in the low dose arm were alive versus 87% in the high dose arm were alive. I mean, 10% total, 10 out of 100 was the death rate difference between the two arms. Okay. The Data Safety Monitoring Board said, we have to close the trial and present the results and tell people about it. Now, that's the type of trial where I have to issue a press release. I cannot say, oh, I will wait for ASH meeting to come, because that will be 6 months that people will continue to be dying with high-dose dex. So you issue a press release that low-dose dexamethasone seems to be associated with significantly lower mortality than high-dose dexamethasone. You issue the press release. Now, there might be some people who don't want to change their practice, but at least you have let them know. And there might be other people who'd say, I can access the protocol online. I have a legitimate NIH-funded group that did the trial. The NCI is involved. And these investigators found that there's a significant risk difference in death between the two arms. And this is a commonly used drug that's commercially available. So there would be people who will change practice based on the press release. And I cannot fault them for that. After all, that's why I'm doing the press release. And then the abstract comes several months later. The paper comes a year later.
Right.
And so it depends on what is the study. If it's a study that's a laboratory study that finds a new biomarker, or if it's a new prognostic factor or a new diagnostic test, I won't change my practice based on press release or the preprint or the abstract. I would wait for the full peer-reviewed paper so I can really, I've already had 4 people's input. Now I'll be the 5th eye and I'll look at it and I'll decide whether to, go for it or not. But for decisions which can affect life or death, then you cannot be rigid with, I will only wait for the peer review, or I will only do this way or that way. You just have to look at the data yourself. If you're not able to, look at other people who have looked at the data critically, and then make up your mind.
There's there's so much, so many pearls in what you said.
So kind.
No, but it is, right? I mean, number one, the blanket statement into I am not going to do anything different because it's a press release is, I would say, a rigid stance of the academy that is not justified, because we need to remember that it's about patients, right? It's you have patients at stake here. Like you said, if you're detecting an oncogene that carries a bad prognosis for a disease, it's not affecting your management. So it doesn't really matter. But this is really very different. I'm glad you brought an example, because these examples do actually illustrate the point. So we talked about the preprints, the manuscripts, the abstracts, as well as the press releases. Are there any other sources of information that the public consumes usually to drive some of their decision making? And I would say that, again, I don't want to talk all about COVID, but in general, like, you know, there are sometimes, so for COVID, there's WHO, the CDC, there are some consensus statements. For non-COVID, you've got ASH guidelines, ASCO guidelines, NCCN guidelines, certain things. And oftentimes, Vincent, when I notice, like, some of these guidelines or consensus statements may not always necessarily be, you know, like, it's really expertise. You bring like 10 myeloma guys, you've done myeloma for 25 years, and you just give some consensus statements. How do you view those in general, consensus statements or guidelines?
This is just an absolutely excellent point that you just raised in terms of how we make decisions, you know, not just the ones that we talked about so far, the press release, abstract, here preprint, original article is the original research itself. And then you have these opinion pieces, review articles, and guidelines, which comment on those original pieces of work and help, and both of them together help you make a judgment call on what to do. But what the viewers or the listeners should keep in mind is, the bigger the magnitude of the difference, the more open shut the case is. None of these make a difference. I mean, if there is a huge survival difference between whether you give dexamethasone or not when people are hypoxic for COVID, then it doesn't matter how many guidelines come out, they'll all say the same thing. And, you know, that's straightforward. So the bigger the magnitude of difference, most of the time, everybody's in agreement. A lot of these guidelines, editorials, opinion pieces, reviews, and the controversies come when the magnitude of difference is not that big, or the endpoint is not correct. You know, the endpoint is actual survival, it's one thing. If the endpoint is, oh, I shortened the hospital stay, or I made somebody's fever, you know, 2 degrees less faster, or I improved their neuropathy score, then you have guidelines and controversies because everybody's now looking at value. They're looking at, for this cost or for this many side effects, is this okay or not? And then you have to enter into all these endless debates with all of these. I think one easy way of categorizing editorials, reviews, guidelines is to look at them as non-anonymous peer review. There are a bunch of experts who are reviewing this original research, but thank God now you know their names.
You just have you want to have just an excuse to meet in Hawaii or somewhere. That's right. That's what it is.
You know who these people are. You can judge their conflicts of interest, their biases, and then you can make a decision. And so I think a good example would be remdesivir. Okay, remdesivir comes out with the US NIH trial showing just a small survival difference, a shortening of the hospital stay, and then the Solidarity trial, WHO, no difference, and then there are other trials, no survival difference. Now everybody's not sure. Should we use remdesivir? Should we not use remdesivir? Is the expense worth it? Is it have risks? Does it have a role? Does it even really work? And that's where all the editorials, opinions, guidelines, everything comes in, where it's not really clear. No one argues whether R-CHOP is good for lymphoma or, you know, ABVD is the right treatment for Hodgkin's, because those are pretty straightforward. So the more you get, and so people need to realize, the more you have to examine reviews, editorials, guidelines, the more likely that the differences are not that big.
So my last question along these lines, and again, really the topic is how do we consume information to take care of patients? And this one, I'll admit, I struggle with this one. I personally struggle with this one, and I'd love some guidance from you and for listeners. So sometimes the trial is not conducted in the US. Now, we're not talking fraud. We're talking, trial happened in Japan, in Asia, in Europe, in whatever. And there's a conclusion of that trial, and it's a positive conclusion. And the question becomes, how transferable data in interventional studies of therapeutic intervention, we're not talking reviews or epidemiology or things like that, how transferable that to the patients here? And I hear different views, and I'll stop. I would like you to clarify this for us. One view says, if there's a trial that actually happened and the trial is positive, repeating that study, the same study in US population, is waste of resources, and you could be denying something very important and effective to these patients. And I hear the opposite view, that we should do it because there are additional factors. First of all, pharmacogenomics may be different in Europe and Asia than the US, drug metabolism, environmental factors, other things. So how do you reconcile this when you have trials being done elsewhere and you apply that trial data here in the US where you practice?
That's a great question. If step back and you look at most oncology trials, I look at most myeloma trials that I'm familiar with, all the large phase 3s. Even though they look like maybe they are US trials because they published in US journals with US authors all over the place, first, last, everything, 95% of the participants are enrolled abroad. And if your question is, does what works in them apply here, because there might be racial, genomic, whatever else differences, it doesn't matter whether the authors are from America or the companies in America, where were the participants from? And most of oncology trials, big phase 3s, most of the population is outside the US who's enrolled in the trial. There's a small number of people who are enrolled in the US. We do approve drugs based on those trials. Almost all the myeloma drugs were approved, whether it's carfilzomib or daratumumab. All of the full approvals came from trials where most of the accrual were from overseas. We did not insist on a separate US trial, but these drugs are then used in the market, and you don't actually need even a single US patient to get a drug approved if it's a good randomized trial. So keep that in mind. But your second point is, we do that. Is that the right thing? That's what you're asking. Just because we do it, does it make it right? And I've been a little nervous about this, mainly because of the racial disparities. Many of the large randomized trials have hardly any African Americans in them. And there are important reasons to think that drug metabolism and other things, dosages and everything, could be different by race groups. And so I think to an extent, we don't need to replicate the trial, but at a minimum, we can require that the trial demographics look similar to the US or close to the US in some way. So that, right now, if you have 2% African Americans in a trial, make it at least 5 or 10%. You don't have to make it 13, but somewhere close to what the population is here, to make sure that we are fine, that we're not missing an adverse event, or we're not missing efficacy signals by not having that. So that's what I would say. Yeah,
no, agreed. And I think it would require a lot of effort to do that, change the inclusion-exclusion criteria. I would say we could be less strict in some of we could be more pragmatic in some of these things.
Can I tell you an anecdote just to describe what we've been talking?
Please, I love anecdotes.
So that the listeners have a take-home in terms of what they are supposed to do.
Yes, please.
So when I was in med school, I read a book called This Remarkable Drug Has Been Overlooked. It was a book I found in the library in the medical school, and I read it. And at the next day, I was like, as if I have found something that no one in medicine had known about. And the drug was Dilantin. And the book had literally 100 different diseases that Dilantin can cure.
Cure.
You have abdominal pain, you take it and it goes away. You have neuropathy, you take it, goes away. And it just goes on and on with chapter by chapter of various diseases for which Dilantin works, with the number of patients, exactly, that they had neuropathy for 10 years, now they took it, and then the neuropathy went away, and 5 years have gone by, they never got the neuropathy, that kind of stuff. Okay. And I said, oh my God, we have really missed this drug. This is something that could cure everything. And why are we not using it? We are using it only for seizures. And I took it to a colleague of mine who was at the time very good in critical appraisal. And he told me about critical appraisal, about what to look for and how not to get, fooled by anecdotal type of information. And then from there, you start reading the, user's guide to the medical literature, all those algorithms on how to interpret a study and how to go through a study. I'm talking in the year 1998, 99, at that period of time. Read David Sackett's book, Fletcher's book. But the point is, ultimately, as physicians who are responsible for patients, when we prescribe something, we need to know how to critically appraise whether it's a press release, whether it's an abstract, whether it's a preprint or a peer-reviewed publication. We need to know how to critically appraise them. And if you're not confident of that, learn it. And if you're busy and you don't have the time to look at drugs that you don't commonly use, then you look to people who you trust, who are good peer reviewers, who are good at critical appraisal, and see what they say. And that's, in other words, editorials, reviews, and articles written by experts you trust who don't have conflict of interest.
Yeah, and that's important. Look, frankly, I think people are very busy and they are consuming things by Twitter or by short forms. And one of the tweets I one time put several months ago is that, before people lived in the entire papers and the abstracts and the conclusions, like our attention span is small. I mean, I'll admit, look, for certain things I'm not interested in, like if just like, some disease in gynae oncology, which I don't have really a lot of interest. I read just the conclusion of the abstract and just move on. I just want to know what's going on, like, what's happening. And certainly for lymphomas or malignant heme, I read the entire paper because I'm just very interested in that. And I believe a lot of people are in the same boat. In community oncology, when you are now have to have the breadth of everything, it's impossible to do that for everything. So I do agree that relying on editorial comments and it's going to be important. Did I miss anything, Vincent? Did we cover all of the spectrum?
No, I think we did cover. We had a good discussion on each of the categories, and obviously you cannot make any hard conclusions, and that's the main thing that you want to leave the listeners with. You don't want to make a blanket statement. Oh, I never practice medicine by press release, or I mean, you could.
I think we should write. I think me and you should write a viewpoint on that.
Yeah.
Sure. I'm actually serious. We should talk about that because I just think there's something there. I just feel that it's really important to recognize this. I mean, it does take time from submitting your paper until it is out even online. I actually think for your journal, it's pretty ambitious that you can get in 3 to 4 weeks. So it's good, obviously, for maybe some very high-end papers. But really, a lot of papers just take way longer, even in this day and age. Definitely better than 20 years ago, but it does take time.
It does. In fact, one of the great COVID papers that I was not an author on, but I heard about was a paper by Jeremy Howard and colleagues on the role of masks for preventing COVID. That was a preprint, I think, somewhere in April of 2020.
Oh, wow, that long ago, okay.
And it was the most downloaded preprint in that server by middle of the year even. But it took almost a whole year for the paper to get published.
Yeah.
But because, there are people who like what you have to say and people who don't. And by the time it goes through multiple journals and multiple revisions, sometimes it can take a long time. All of that we talked about is a lucky paper that goes through
Yeah.
a quick peer review and a quick acceptance. But I've had papers which had to go to 4 or 5 journals before they finally got published.
Hey, there's a journal for every paper out there.
There is.
Thank God. If it wasn't the case, I would be in big deep trouble. Vincent, thank you so much. It's always nice to visit with you, and you're always generous by giving me time and giving listeners time. I really appreciate it.
Thank you so much for having me, Charlie.